Thank you, Asim, and thank you, David, for the invitation again. I will try to give some information about why robotic bariatric surgery. Actually, I will try to share my screen first, and let me get the presentation here. This one. Okay, we are all set. You can see my screen now?
Yes, we can see your screen.
Okay, so bariatric surgery, as you know, I mean, since the introduction of the discovery of the wheel, there are always some people who are actually against the new technology. We have seen that. I mean, I'm not as old as the history of the laparoscopic cholecystectomy, but I remember the first case I have done in 1992. And since then, we are criticized of doing laparoscopic cholecystectomy, as it has been blamed and explained as a threat for the patient. Since then, there are a lot of development and changes on the technology and the surgical sites, and we can see that we have started in the past cut and see. We used to cut and see inside, and yesterday it was laparoscopic, and also we use ultrasound scan to see inside and then decide to cut. Today we are using the technology of seeing and minimally cutting the patient, and in the future I believe we are going to use virtual reality and augmented reality to decide and to do the surgery by using planning, modeling, and vision all together. So if we look at, I cannot change the slide. Okay. If you look at the laparoscopic surgery, and you will see that laparoscopic surgery, there are some numerous handicaps, loss of haptic perception, and the movements of the, let me see my slides in a proper vision. I cannot get it because of the pool. It's actually on my top of my slide. So I can change this one and close that one. Okay, this is much better. So there are numerous handicaps with the laparoscopy, and as you all know, that haptic perception is lost, and movements is actually restricted to a fixed pivot point on the abdominal wall, and also loss of direct visualization and the use of two-dimensional information in order to perform the 3D maneuvers makes it quite difficult. So first three is quite difficult to change, but we can change 2D to 3D by doing this one. 2D imaging system will give us a chance to overcome the information discrepancy. But I have to say that with the development of laparoscopic surgery, if we look at the history, we will see that from the single dimension to high definition, and then the 3D high definition system is there, and we also had proper operating room designed for the new technologies. So, and also if you look at the instruments used for the laparoscopic surgery, it's actually developed from straight to articulating instruments, and also the cauteries from monopolar to energy-based devices like harmonic devices, and also ligature that we are using currently. I wish we had a forearms. That was a slide from my friend Arun Prasad from India. If we had a forearms, that was going to be quite easy to do laparoscopy. In the meantime, you can also have some other things by doing your surgery. Actually, we have forearms with the robot. Robot has a central arm with the camera, and also there are arm 1, 2, and 3 for the instruments, and also designed it with the shoulder, elbow, and the wrist that we are as a human using like that. An instrument with 2 fingers with 360-degree movement will make life easier with robotic surgery. So this is the surgeon console. you need to sit on that console while you are doing your robotic surgery. There are 3D googles and the finger loops to control the instruments and the telescope. You will control everything. And you can keep your arm rest with the controls. And also you have foot pedals for energy devices, and you can switch pedals. You can change the screen and change the instruments with your control. Advantages of the robotic surgery: first, steady robolift and grip, and true 3D experience, and extreme angulation for dissections. All 4 ports actually under the control of surgeon, and the anastomosis is easy with 360 degrees articulating fingers. So if we get all together, we will see that Da Vinci surgical system at the moment, but I know that there are numerous new robotic systems are coming this year and the next year for the surgeon's use. So the difference between laparoscopy and the robotic systems based on 3D vision, motion scaling, and also tremor filtering is possible in robotic sites. Also, the magnification is much more than laparoscopy, and also it is ergonomically intuitive for both for surgeon and the patient. So if we look at the screen, you will see that simulations and the simulators are also coming with the systems that you can actually train your registrars by doing your surgery, and they can come after surgery and do some simulating procedures and gain experience. So I believe currently it's over 3,500 simulators installed in all available systems. When I was doing a lot of laparoscopy before I had the robotic experience, I was having a lot of pain, back pain, pain on my shoulders, and pain on my arms and all that stuff. So I decided to do a study on looking for ergonomic problems by the surgical team, which is published in Surgical Laparoscopy and Endoscopy in 2008. And we conclude that the laparoscopy is actually causing a lot of problem, and the special operating room establishment and the special instruments needed and for surgeons in order to avoid this kind of problems, especially even for the young surgeons. So with the robot, you will actually overcome most of these problems. There are many publications on that. And I would like to show you some of my videos during my talk. This is sleeve gastrectomy. You can say that sleeve gastrectomy is not a proper operation to do with robotic surgery, but I will show you this and let you to decide. If you forget about the cost, it is easy with the robot as well, and especially for someone who is starting robotic surgery as a bariatric surgeon, sleeve gastrectomy is the procedure of choice to start with. We used GastroSail by Medtronic, as you can see here. That makes life easy, and also because of the Firefly of the robotic system, you can see the lights. Also, you can use indocyanine green, especially for colorectal surgery, but also you can use indocyanine ICG for the to check your anastomosis blood supply. And you can see here the technique and the steps of the sleeve gastrectomy or the bypass, I will show you, is same as the laparoscopic procedure. But I don't know whether you are seeing as good as I am seeing now here. The view and the magnification is much better than the laparoscopic procedures. Also, 3D view gives you a greater chance to control the anatomy and to avoid the complication related to dissection or the anatomic differences of the patient. And then we can go downwards to the pylorus. I usually do go 2 centimeters to pylorus and start transecting the stomach from there. And you can see again here Firefly of the robotic system. And we are using iDrive. You can have actually stapling arm of the robot, but it's quite expensive that we are using iDrive from Medtronic, which is giving a better chance than ordinary stapling device. that it controls the thickness of the wall, and we are using triple stapling technique here. Sleeve gastrectomy, that will give you chance to avoid the complication. I would like to add Michael's talk was quite good, but I would like to say that narrower the sleeve, higher the pressure, and it is also higher the rate of complication. So I always try to avoid to make a narrow sleeve. I use 40F bougie, and I try to stay half centimeters away from my bougie when I'm stapling the device. I do not oversew the stapling line, but I always put a couple of stitches on the omentum in order to avoid bending of the stomach after sleeve. So that's gonna help you to fix your stomach, and it is gonna stop stenosis because of the bending of the stomach after sleeve gastrectomy. So this is sleeve, and we compare the first 30 robotic sleeve gastrectomy with the last 30 laparoscopic sleeve gastrectomy. All of them done by myself. I have done over 1,000 sleeve gastrectomies laparoscopically, but I have to say that I have done something like 50, 60 sleeve gastrectomy robotically. Based on this study, I can say that for sleeve gastrectomy, there is no advantages for robotic surgery over laparoscopic surgery. However, if you are a bariatric surgeon and if you convert your practice from laparoscopic to robotic, sleeve gastrectomy is the procedure of choice to start with. So if you look at the gastric bypass and comparison between robotic and the laparoscopic gastric bypass, there are many studies, and initially published papers in 2013 by Teo et al. Concluded that the main difference between laparoscopic and robotic are actually only on the gastrointestinal leak rate, which is less on robotic side, and also major complication rate is higher on the laparoscopic side. But if we look at the new papers based on the database analyzes, including over 100,000 sleeve gastrectomies, concluded that there is no difference between robotic and laparoscopic sleeve gastrectomies. As I said, it might be used to start with when you are converting your practice to robotic surgery, but I believe it is because of the cost of the robotic surgery. In the future, when the cost comes down, everything is going to convert to robotic side from laparoscopic, and we will see that sleeve is going to be done robotically as well, as it is quite easy to learn, and it's also quite easy to perform with less complication. So we start doing mini gastric bypass as well as Roux-en-Y gastric bypass. I have to say that first mini gastric bypass done by Robert Rutledge laparoscopically in 1996, when first robotic one done by Arun Prasad, I believe he published in 2014, including 14 cases or something. And as far as I know, he performed over 200 cases. We are using robotic system since 2016, end of 2016 for bariatric surgery. We used to have it before than that for colorectal surgery. Since then, I performed 90 robotic MGBs. Altogether, my MGB is about 675 mini gastric bypass I have done, including laparoscopic and robotic together. So 55 duodenal switch and 40 sleeve gastrectomies, 45 sleeve gastrectomies robotically. And we also did 25 revisional surgeries with no complication, without any complication any major complication by using robot. And I can say that mean excess weight loss in 2 years' time is more than 75% of the patient. So you can see on the picture that Rutledge was in Turkey and giving me my certificate of doing perfect MGBs seen by himself. You can see one robotic MGB here. I always try to use Nathanson retractor for this kind of patient because most of my patients are actually over 45 or 50 BMI. So that retractor, liver retractor makes life easier. And robotic in this kind of patient, I believe, because of giving more space for you to perform your surgery and the better view as compared to laparoscopy makes life easier in patient with the BMI over 50. We always start for the MGBs, we always start from the lesser curve, opening up a window to see behind because you need to turn the stomach, and then just below the crow's foot, your size, your length of your stomach stomach tube needs to be around 18 to 22 centimeters at least. Otherwise, the patient will be suffering from the reflux symptoms. So again, you can see here, I use iDrive as a stapling device, and I use triple stapling for the robotic surgery as well. And I use bipolar on one hand and ProGrasp on the other hand as a robotic instruments. And then we go upwards till gastroesophageal junction. We try to stay away from that at least 1 centimeters or 2 centimeters. For the mini gastric bypass, the most important thing is your suture line, and the bougie is always inside. You need to follow your bougie, but you don't need to make a narrow tube as you are doing as narrow as your sleeve. It can be a little bit looser than your sleeve tube. Go upwards. Because MGB is malabsorptive procedure, restrictive part is also, I believe, important, but it is not important for the weight loss. The most important part for the weight loss is the length of the small bowel. So you can see that we just reached the gastroesophageal junction, and then we start counting from the triceps ligament. We always count whole length of whole bowel, and I have to say that in Turkish patient, even if we go to 300 centimeters, which we are doing for the duodenal switch, there is always a mean length of 4.2 meters of the small bowel. So we know that if you stay 150 centimeters from the triceps ligament, as some of my friends in Europe are doing that, you will end up your patient having putting a lot of weight on in 2 years' time. Metabolic control, for metabolic control, 150 might be enough, but for the weight loss in someone with a BMI over 45 to 50, 55, 60, 150 is not enough. So this is the anastomosis, as you are seeing here. Then we close the anastomosis by using V-lock sutures. I always put 3 sutures on the gastroenterostomy's afferent part to hang it up. By doing that, I believe that will help to stop the reflux of the bile. So patient is not gonna complain about that. So I always close that whole single layer, and I use 3/0 V-lock suture. After I close that, I put the NG tube on the afferent part of the small bowel, and then I always do leak test for all procedures during the surgery. As you are seeing here, I hang it up, small bowel with 1 or 2 sutures in order to avoid the bile, more bile in the stomach, as it's a loop anastomosis. So when we finished this one, we will always do leak test, and I put 1 Jackson Pratt drain on the, as you are seeing here. Leak test doesn't mean that you will get the leak during the procedure. If there is no leak, doesn't mean that your patient is not going to suffer because of the leak problem. But that will also show you the true way of the bowel, that proximal and distal part is open. So you can see the passage of that as well. So in high BMI patient, we have problem with the laparoscopy because they have thick and heavy abdominal wall. High intra-abdominal pressure is needed, and you have to put more carbon dioxide inside. So abnormal load is actually a problem for the surgeon's arm, which results in the weakness of the arms. And that actually, if the procedure goes more than 1.5 hours, 2 hours, then it will start weakness and you will start make some mistakes. And because of the more abdominal fat in high BMI patient and the bigger liver, it is difficult to see your operation site. Exposure is a problem. So it is also difficult in this kind of patient to make the table tilt up. So if you don't have a special table and special access operating room. So difficulty is also there for dissection, exposure, suturing. All of them actually makes operation risky and longer. I believe robotic surgery, especially in this group of patients, makes life much easier. So I will show you RoboLift in this kind of patient. With robot actually gives you extra space to see and also use your equipment. If you look at the results of the database evaluation in super obese patient, which is published at the end of 2019, but it's not published, it's not printed yet, it's published online. So you can see that there is an advantage. There is not much advantage as compared to laparoscopy for robot, even in this kind of patient. But say they say that number and the centers and the data put in this database is not actually randomized studies to conclude about this. But I believe, as you are seeing here, because of 3D, this is my procedure for the duodenal switch, because of the 360 degrees of articulating, because it is being tremor-free, suturing is much easier. And doing it something with an easier way is gonna stop having complication. So risk of complication is much lesser as compared to laparoscopy in my practice. We are actually preparing and going to publish MGBs and duodenal switch as compared to robotic to laparoscopic, and I will share the results with you on that time. If you look at the time, laparoscopic bariatric procedures, first 100 cases takes longer, and last 100 cases takes much shorter as compared as you gain more experience. It's also same for the robotic bariatric surgery, but if you are experienced laparoscopic bariatric surgeon, when you convert your procedure to the robotic, the time of gaining experience and shortening your length of your procedure is actually, case number is less than laparoscopic one is as well. I have to say that in 10 or 15 cases, you will come back to the same amount of time as you are doing laparoscopically, even you will do shorter than that. So that shows the comparison here. If we look at the revisional bariatric surgery on the database, we have to say that robotic bariatric surgery seems slightly better than laparoscopic bariatric surgery. There is a paper coming in the surgical clinics of North America this year, written by Iran Manesh, and he concluded that potential advantages of robotic bariatric surgery is the instrumentation, easier suturing, which allows hands-on anastomosis, multi-color access, and improved ergonomics for the surgeon. I believe the most important part is, for me, as we get older, the improved ergonomics for the surgeon. So I will show you my robotic duodenal switch video, which is a couple of minutes. And you will see that starting and putting the trocars are actually the same. I have to say that if you are using DaVinci S, DaVinci SI, or DaVinci X, or DaVinci XI, the trocar sites are different. You are seeing the size of the lever and the The steatosis on the liver because of the patient's BMI is around 65 or something. In these procedures, we decided to do a single anastomosis duodenal switch. I am doing my single anastomosis duodenal switch differently than the Saidi, which is done by Pernotte and Torres. I'm doing my duodenal switch like VJ Lee does. I count my small bowel like I count in mini gastric bypass. I count starting from the triceps ligament. In Europe and the United States, they count starting from the ileocecal valve. We found that counting from the ileocecal valve going up actually results in a lot of problem with the bad odor of the feces and also increased number of defecation, and they result in increased number of malnutrition, which we haven't seen any of our patients. So we start based on the size of the patient, we start with cholecystectomy. Sometimes you can leave the cholecystectomy at the end of the procedures, but if you are doing duodenal switch, cholecystectomy is part of the procedure even if there is no stone or sludge in the gallbladder. And then we go on with the sleeve gastrectomy. The steps of the sleeve gastrectomy is same as laparoscopic sleeve gastrectomy, as we explained by Michel Gagne and me in our papers. And we start on the middle of the stomach and then go up forward first and then come down till we are seeing the gastroduodenal artery. When we see the gastroduodenal artery or 2-3 centimeters below from the pylorus, we start transecting the duodenum, as you are seeing here. After the transection of the duodenum, we put the bougie inside, and then size of the bougie is the 39F, and then we do transect the stomach. And for the duodenal switch, you don't need to do a narrow sleeve. You can do a loose sleeve as compared the only single sleeve gastrectomy procedures. So, but you have to follow the same rules. When we have done that, so you are seeing the stomach here. We are going to take it out. You can take it out on this stage, or you can leave it to take it out at the end of the procedures. As you are seeing here, we count the small bowel starting from the triceps ligament, but we count whole length of the small bowel. It's quite difficult to do it robotically if you don't have a special table for that, because you have to change the place of the arms in order to go down further. Otherwise, it is going to be very difficult to go down to ileocecal valve. And then we come to 300 centimeters in this patient from the triceps ligament. I always use 300 for the duodenal switch because all my patients for the duodenal switch are actually over 50 BMIs. And then I use single layers for the posterior layer of the anastomosis by using Vicryl, continuous suturing. It is easy to do it robotically as compared to the laparoscopic one because you can use both hand 360 articulating is possible, and also because of the 3D and better space is going to give you more chance to control everything properly. Even if your patient, I mean, it is difficult to do like that in this patient with laparoscopy because you will get tired because of the pressure on the abdominal wall and the trocar sites. When we open the small bowel, and then I will go on and do single layer again, anastomosis, gastroenterostomy, using a VLAC, trio VLAC sutures. We have done over 100 now. Duodenal switch, single anastomosis duodenal switch, which is going to be published in the Annals of Laparoscopic Surgery. I prepared a special issue for the bariatric surgery. It is coming probably next month. It's coming out next month. You will see all the details of the steps of the procedures, and also there are papers from European colleagues on the other procedures as well. So as you are seeing here, we close the hole by using single layer, trio, VLAC sutures, and NG tube is actually passed down the efferent part of the distal part of the small bowel. We always do leak test. I mean, difficult sometimes if the patient is too heavy and the BMI is over 55 or 60, sometimes to do MGB is quite difficult because you cannot actually get the small bowel up because of the fatty meso and small meso. So duodenal switch, because of the length of the stomach, is going to give you a chance to do a better one. If you look at the change of the color on the stomach, on that side, you can worry about that, but I have to say that if you wait 15 to 20 minutes, you will see that the color is gonna come back to normal color. And so when you compare the cost, most criticism comes for the robot is because of the cost. I believe we can compare the cost because the cost of robot is coming down. As compared, we had to change our laparoscopic system many times when the technology changed. So when you compare the cost of that, it's going to come and it's going to take you up to cost of the robot probably. And because of the comparison on the industrial side, I believe the cost of the robot is going to come down next year. In Turkey, we have 36 console and the system in the hospitals. Most of them are actually located in the private hospitals, and the government has something like 20 now. The number is being accurate now, and the number of surgeries are actually getting increased, and mostly it's being used for the colorectal and the surgery and the urologist, by the urologist. But also, I have to say that number of bariatric procedures are also increasing as compared to colorectal one robotically. So during all my career for the last 30 years, I started surgery in 1989, and I can say that laparoscopic surgery as compared to open surgery, getting better and access, and also it is better with the results as compared to open one. I believe it does not augment the surgeon's full potential. If you actually, with the laparoscopic surgery, you cannot put all of your potential to the surgical side. But when you compare the single port, multiple port to open surgery, I have to say that single port seems better than multiple port, but you need more potential and more skills to do a single port. For the robotic part, single port robots are coming with the spiders kind of fingers, and as compared to laparoscopic one, robotic surgery actually not only augments the surgeon's full potential in routine cases, but also it can adjunct with different options when a so-called routine case becomes a complex case. And also, future expectation for bariatric surgery is the accurate dissection, which we need on the robotic part, errorless suturing, which can be done by the robot itself with the technology. It should be reproducible. It also gives us a chance to train the knee surgeon, which is possible with the simulators available at the moment. And we need to use computers to our advantage. And I will tell you, and we need to use the artificial intelligence for which you can see single port and spider arms. Advantage of the robotic surgery is actually summarized here. And I have to say that there's another review on the role of robotics in the bariatric surgery. It's actually robotics to find or feature. Yes, we have to learn robotic surgery, not for the bariatric surgery only. We have to use robots if we want to stay on the lake of surgery for the future. And this is our new chapter, which I wrote with my son, who is actually doing his PhD in Santa Barbara, California, on computer engineering, and he's actually interested in robotic. We did write a chapter for the digital surgery, edited by Professor Sam Atala, and on artificial intelligence for new generation medical robotics. I believe with the artificial intelligence, we will see a new chapter, a new feature for the robots on the surgical side as well. So my comment is new technology is here to stay. We should not left behind all of that, and priority remains preventive and the primary care, yes, but there are some surgical benefits established from the robotic surgery. Currently, the number of the centers with the robot is quite low. That number will be increased when the cost comes down, and that's why we have to be rational and give surgeons a chance for the effective utilization. Even if you don't have a robot, you should have an access to go and do robotic surgery in a special center if you had a special training for that. So I have to say that without a team, you cannot do robotic surgery. This is my team of 2 assistant professors. I do all the cases with them. We also have a new professor in my team, Professor Munawar Moran. She is not in this picture, but she is the part of the team now. We take care all of our cases with this team, because you cannot actually overcome the complication and the problem of the cases. And you also need special training and special certification for the robotic surgery based on the numbers and the success of your procedure. It's given by the company, it's an industrial part itself. And also we did write papers for the popular science journals that robots are coming. We cannot avoid to use robots, otherwise they will use us and they will control everything. Thank you very much for your attention. I would like to finish here, and I would like to have the question if there is any questions.